Hi, everybody, and welcome to the New Retina Radio Journal Club with VBS. I'm Eric Nudleman. I'm an associate professor of ophthalmology at the Shiley Eye Institute of UC San Diego. And I have the pleasure of being joined today by my friends and colleagues, John Miller, who's an assistant professor of ophthalmology at Mass Eye and Ear.
Hi, Eric.
Thanos Papakostas, who's in private practice with the Retina Institute in St. Louis.
Hi, Eric.
And Priya Vakharia, who's also in private practice with the Retina Vitreous Associates of Florida in Tampa, Florida. Hi, Priya.
Hi, thanks for having me.
Great, thanks everybody for joining me. So first we're going to discuss a set of pieces on retinal detachments, which compare the outcomes of vitrectomy with pneumatic retinopexy. And then after the break, we'll have a deeper dive into these two papers and discuss their clinical relevance. So let's kick off the discussion with our pair of papers. The first one is a post hoc analysis of the PIVOT trial. The title is Outer Retinal Folds After Pars Plana Vitrectomy versus Pneumatic Retinopexy for Retinal Detachment Repair. And the authors are Wei-Wei Li and others. And it was published online in September of 2021 in Ophthalmology Retina. So John, you want to help us out and summarize the first paper?
Thanks, Eric. Yeah, so as the title indicates, this is another paper from the PIVOT trial from Mooney's group up in Toronto, who's really leading the way and kind of analyzing how we can improve retinal detachment repair and specifically looking at imaging biomarkers. So this was a randomized controlled trial assessing postoperative outer retinal folds, a post hoc analysis of the previously mentioned PIVOT trial. So they were looking at the incidence of outer retinal folds after both vitrectomy and pneumatic retinopexy at 1 month on OCT. So they had 88 eyes that were MAC off, and 83 of those had gradable OCTs at 1 month. In the two groups, there were 41 eyes in the PPV group and 42 in the pneumatic retinopexy group. They used a specialized algorithm to look at a specific section to identify these outer retinal folds with en-face slabs on the OCT. They were all graded by 2 mass graders at 1 month. They then also assessed visual function by an ETDRS letter score and quantitative metamorphopsia assessment at 1 year post-op. So just remember, this is a post hoc analysis of PIVOT. There are only 83 patients total who were evaluated and all had to be attached. So obviously there were some participants lost from the original treatment group for those that failed to achieve success with the first procedure. When they looked at the incidence of outer retinal folds, there were 34% of these folds in the vitrectomy group and 14% in the pneumatic retinopexy group. This was associated with statistically significant differences in the ETDRS letter scores at 1 year. In the vitrectomy group alone, there was a mean ETDRS of 63 letters in those with ORFs and 75 letters in those without outer retinal folds. They also compared the horizontal and vertical metamorphopsia scores and found that those were similar in patients with and without outer retinal folds. The main take-home point from the authors was that their outer retinal fold risk was much greater in the group with vitrectomy versus the pneumatic retinopexy, and they offered several different hypotheses. This links to some of their other work looking at ellipsoid zone loss, but the idea was that generally a slower reabsorption of the retina that retinal subretinal fluid and pneumatic retinopexy led to less of these outer retinal folds. In a vitrectomy, we're drying out the retina really quickly. And the idea is that this sort of pins the retina and leads to some of these folds, which can make more distortion or more visual abnormalities for patients at 1 year. They also found these outer retinal folds were worse, associated with worse visual acuities at 1 year. So I think this, like many of the other papers from this group, does give some support to the idea that pneumatic retinopexy should still remain a viable option. I think more work is probably needed to help analyze this concern, and I think that the vitrectomy group did show that more of this metamorphopsia in their analysis as well as outer retinal folds.
All right, well, that was a fantastic and comprehensive summary. Really appreciate it. Thanos, what did you think? What's your first quick reaction to that paper?
Yeah, this is an important paper from an excellent group in Canada, Dr. Mooney's group. They've done a phenomenal work over the last few years to try to dissect what exactly the role of pneumatic is and all the characteristics associated with it. Now, a couple of points is that all these outer retinal folds will eventually go away. So at 3 months, it's about 10% of the patients in the vitrectomy group and about 7% in the pneumatic group. At 6 months, all the folds were gone except for one patient in the vitrectomy group. Now, the notion that the presence of the outer retinal folds is associated with poor vision, in my opinion, based on the p-values on the paper, it's more like a trend. I don't think a p-value that is close to 0.05 with these small samples can give you like a clear-cut conclusion. So I think it's more like a trend. It has to be validated with a larger sample size, but the bottom line is that these folds will go away eventually.
Great. Yeah, we're gonna dig down on some more details after we discuss the second paper, which Dr. Vakharia is gonna summarize for us. Priya?
Yeah, so I'll just go ahead. So the second paper is the Align paper. The title is Retinal Displacement After Pneumatic Retinopexy versus Vitrectomy for Rhegmatogenous Retinal Detachment. The authors are Carolina Francesoni et al. And this was published online in December 2021 in Ophthalmology Retina. So this was a prospective, non-randomized comparative trial that assessed the incidence of retinal displacement following pneumatic retinopexy or vitrectomy. This was done in 3 centers, one in Toronto, Canada, one in the United Kingdom, and then one in Hamilton, Canada. And basically what they're looking for is something similar to the study we just mentioned, except in this, mostly they're looking at retinal displacement. And so they're comparing these 2 groups to see the difference in retinal displacement. And in this, conversely to what John just mentioned, here they're looking at 3 months postoperatively. They use 2 masqueraders to assess postoperative OCT and fundus autofluorescence images to look for retinal displacement. And they also looked at best-corrected visual acuity, metamorphopsia, and then anisoconia at 3 months post-op. So in summary, they had 157 patients total in this group. A relatively balanced group, 74 patients underwent vitrectomy and 83 underwent pneumatic retinopexy. Of note, the pneumatic retinopexies were often performed within 24 hours, while the vitrectomies were often performed within 72 hours. The pneumatic retinopexy group did have an initial face down and steamroll for as part of their protocol, whereas the vitrectomy group did have an initial face down as well for 24 hours, followed by positioning of the brake. And when they looked at the primary reattachment rate, because of course, retina specialists are concerned about primary reattachment, they did have 93% in the vitrectomy group versus 82% in the pneumatic retinopexy group. And among those who had achieved primary reattachment, there was 51% in the vitrectomy group who had retinal displacement on fundus autofluorescence versus 15% for the pneumatic retinopexy group. And that was deemed to be statistically significant at a p-value of less than 0.01. Now, among the patients who were initially intended to be treated with vitrectomy or pneumatic, regardless of whether they achieved primary reattachment, there was a 50% rate of retinal displacement in the vitrectomy group versus 25% in the pneumatic retinopexy group, again, statistically significant. Among the 2 groups, there was no differences found regarding epiretinal membrane, cystoid macular edema, residual subretinal fluid. And overall, the visual function among these 2 groups did trend towards having better outcomes in the pneumatic retinopexy group. The vitrectomy group had about a logMAR of 0.50, whereas the pneumatic retinopexy was 0.33. Similar to the study that John just summarized, the anisoconia scores were worse in the eyes with vitrectomy versus pneumatic retinopexy, although they had similar vertical and horizontal metamorphopsia findings, again, similar to the PIVOT trial. And so in conclusion, the authors came to a similar conclusion as the PIVOT trial, which is that vitrectomy is associated with greater risk of retinal displacement compared to pneumatic. Postoperative retinal displacement was associated with worse anisoconia and rhegmatogenous retinal detachment patients. The biggest difference between this and the study that John just mentioned, again, is that they looked at retinal displacement in this study.
That was another beautiful summary. Thank you very much, Priya. So Thanos, your reactions to this paper?
Yeah, another very important paper by the same group. A few key points to remember in this paper. The pneumatic group, the procedure was performed within 24 hours, while in the vitrectomy group, it was within 72 hours. So as we know, in a macula of retinal detachment, even macular retinal detachment, timing is key. We know that photoreceptors die through the process. So perhaps, there is a bias there depending on the timing. So if you let more fluid accumulate, perhaps you might have more displacement when you put the macula back on. That's one thing. The other thing that strikes out is that there is a difference in the single surgery success rate. The pneumatic group is around 80%, 82%, and the vitrectomy group is 93%. So it is a sizable difference. It's around 10%. So basically for every 100 pneumatics that you will do, around 10 will probably need another surgery. So it is a sizable difference. It seems that the larger detachments didn't really matter if it was 1 quadrant or 2 quadrants or 3 quadrants. Now, when they're talking about anisoconia, it's essentially micropsia or macropsia. And that's something very important that we really haven't looked in the past. And this paper does a beautiful job trying to analyze it. So overall, success rate matters. That's our primary goal in retinal detachment surgery. However, the quality of the vision matters too. So we have to probably pick the right patients for each procedure.
Perfect. Thanks, Thanos. Those are all really excellent points. So at this point, we're going to take a quick break. And I want to remind the audience that we're going to have a more in-depth discussion when we come back. Hi, everybody. Welcome back to the New Retina Radio Journal Club with VBS. I'm Eric Nudleman, and I'm here today with Priya Vakharia, John Miller, and Thanos Papakostas. Now we'll be talking about the clinical relevance of the 2 papers we discussed before the break. So Thanos, I thought it was really interesting that they quantified both anisoconia and metamorphopsia. Is that something that you routinely do in clinic?
Yes, thank you for the question, Eric. That's something that we don't routinely do in the clinic. And in order to, figure out exactly how they did this test, you have to actually look it up, because that's something that, we probably haven't done since training. But to summarize, metamorphopsia is calculated with the M chart. So you have a set of vertical lines that then are flipped horizontally, and depending on the gap between the lines, a score is given for metamorphopsia. And then for anisoconia, the patient is wearing a red glass in one eye, a green glass in the other eye with half circles. And then when the patient sees one circle, then they basically quantify the anisoconia, the extent of the anisoconia. These are very specialized tests. We don't do them in everyday clinic. We only record subjective complaints that the patients have. So it's a little bit hard, for the audience to translate these numbers to something tangible that we know. Despite that, it's a very scientific way to monitor things and check the progression.
Yeah, I agree. Anisoconia is not an uncommon complaint after repair of a macula off retinal detachment. What do you usually tell your patients, Priya, when they complain of anisoconia? They say, I close one eye and the other eye has a little small image. What do you tell them when they explain that?
Yeah, it's hard. I tell them that it may get better over time. Things can improve up to 6 months to 1 year later. And I think as retina specialists, we're all so focused on reattachment that sometimes, I have to admit, I say the macula looks great, the retina looks great, you look great, you're attached. And I pat myself on the back because they had a macula off detachment with 27 tears and lattice, and they look great. But these complaints are not small, and to have a patient have anisoconia can affect their work and everything. So while I provide reassurance, I actually thought it was nice that there is a way to quantify this. which I don't do in clinic, like Thanos mentioned. But yeah, I usually tell them it can improve up to 6 months to 1 year later, and either it does improve or they stop complaining about it. I'm not entirely sure which it is.
Yeah, I have the same experience. I always tell them, you got to give it some time. It can take up to a year for you to reach your final potential. But I thought it was quite sobering that in this study at a year, they still found a significant difference. John, does that affect your decisions about how you would deal with a retinal detachment?
Yeah, I mean, I think the study was interesting, but I'm not sure that it convinced me to really change my practice. I think that there's, many different ways to repair retinas, and I think there's a lot of patient factors and sort of training and personal preference, surgeon preference factors as well. So I think most important is to do what you're good at and to do the right procedure for the correct patient. So I am pretty selective in the patients that I do pneumatics on, but I think that our approach with vitrectomy, I don't really see this that commonly in my practice. I certainly don't see as many outer retinal folds as was reported. Admittedly, I don't look as carefully as these authors did with mass graders and carefully segmenting, but it's not the common thing I see postoperatively in my patients. So I still think that vitrectomy is a very good option. I think the higher success rate is still what I would lean on. The pneumatic success rate in the trial was admirably very, very high, above 80. I don't think that many other papers show pneumatic success as good as these authors achieve. So I think that's very impressive, and that may be why there's a closer score with some of these metrics that they looked at.
Yeah, the changes were quite subtle, actually. When I saw those images, I see that all the time after detachments, and I think it looks pretty good. Retina's attached. I hadn't previously paid much attention to the changes that you see on an OCT, for example, like the ones they showed in these papers. Thanos, do you pay? Had you noticed that previously?
I mean, I do pay attention for outer retinal folds and all these structural changes we see on the OCT. I have to say that the displacement that they see, you can only pick it up if you do the wide-angle autofluorescence. So sometimes you don't even have the machine in all the satellites that you go to. You might not have autofluorescence on a wide-angle camera, so it's a little bit harder to pick it up then. The other thing I would like to make a comment on is anisoconia can be either from micropsia or macropsia. So you have micropsia when the photoreceptors are essentially stretched or they're attenuated. You can have missing photoreceptors. And macropsia, which is the opposite, which is quite rare, is when the photoreceptors are more packed together. Mm-hmm. Now, a component to the anisoconia is just the fact that they had a macula of retinal detachment. There is attenuation of the ellipsoid zone. So I'm not 100% convinced that the anisoconia is from the displacement. It could be multifactorial. And in some people, it could be less. In some people, it could be more. But I'm not 100% convinced that the displacement is the one that is causing anisoconia.
Yeah, they do show a illustration of how the anisoconia can occur, particularly with the micropsia. So when they show the inferior displacement of the retina, you see the shadow of the previous location of the vessel and the vessel below it. So if that's the case and there's inferior displacement, you would get the micropsia.
The other thing that struck me about that example, Eric, is that there was a lot of heavy, there was a lot of laser in that patient with that repair. And I do think that probably does contribute. And maybe that's another reason why there's potentially more retinal alterations or twisting than you would get with cryoing a single tear. I think people are a little bit more loose in the amount of laser that they might put in if they're already inside vitrectomizing an eye. So I think that's an important consideration, is how exactly is the vitrectomy being done, and what, because there are so many different small decisions when you're repairing a retinal detachment.
Yeah, I agree. I also thought it was interesting, they had to be able to get an OCT at 1 month through the macula in order to do the analysis and the post hoc analysis of the pivot trial. And that means that they must have used SF6 in those cases, because if they used C3F8, most likely they wouldn't be getting an OCT through at least all of the macula at 1 month. Do you think that that influences the results at all? Would it be different if they used C3F8?
I don't think so. I think, you know, the point here is that the point they're trying to make is that they want minimal gas in the eye. They don't want full gas fills. That's why the lead author of the group is advocating when you have to do a vitrectomy, do a minimal gas vitrectomy. So I would assume with SF6 they got a full fill at the end of the case.
Yeah. Priya, how do you think primary buckles fit into the algorithm here? Do you think that they would develop anisoconia, metamorphopsia similar to a detachment or pneumatic, or not at all?
That's a good question. I think the theory for why patients get this is that in intra-op in a vitrectomy, when you make a retinotomy or you drain through a retinal break, you are mechanically draining fluid and suddenly reattaching the retina. And there are different portions of the outer retina that are in different stages. Some are still swollen, some are dehydrating. And so you get these folds because you have this abrupt mechanical reattachment. So if that, and in pneumatic, the reason it doesn't happen is because you have this more gradual reattachment where the RP is pumping out the fluid. And so everything kind of progresses at the same rate. So in a primary buckle, you know, most of the time you're draining, but I mean, I would say we're usually not draining completely flat. Yeah, there's always some residual fluid. You usually get the break flat on the buckle, but at least in my experience, you always still have some residual posterior fluid. So I would actually expect you would not get as much outer retinal disruption or outer retinal folds in that case. And I haven't really seen it as much in my patients with primary buckles, although I do have to admit, we don't do primary buckles as much as we used to. It's really in a select set of patients that we do primary buckles, but I would expect it would not be there.
Yeah, I agree with you completely. And I rarely get a complete drain. I do a lot of primary buckles. I take care of kids, and so I'm often doing primary buckles. It can be very slow to get the retina to completely reattach. Sometimes you get these little pockets of subretinal fluid that can take months or even up to a year to go away. But anisoconia and metamorphopsia is not a common complaint. But I would think that that would be a nice additional study to do, looking at the same metrics.
You know, I do want to ask a question. Would these papers make any of you more willing to do a staged pneumatic to vitrectomy? You know, something they'd oftentimes do in Europe, which is putting in a temporary gas bubble, reattaching the retina with that, and then going in for a vitrectomy and surgically repairing it there. Let's not take cost into consideration, because I know that's a big issue with that, but would that change any of your opinions on that?
Thanks. Great question. I sort of consider all pneumatics a potentially staged procedure. If you think of a pneumatic success rate working 3/4 of the time, if it's not working in the first week, I'm going to do a vitrectomy. So I don't do a lot of pneumatics, but when I do, I'm certainly prepared to do a vitrectomy if it doesn't work within a week. So it doesn't change my plan. I'm influenced by being in a situation where I have an OR available 24/7, and I think that the groups in Canada are influenced in the opposite way. So I think that these papers are quite compelling. It does actually make me reconsider my treatment algorithm. Perhaps I will do more pneumatics if additional studies continue to confirm these findings. And doing it in a staged way, I think you lose little. If you do put a gas bubble in and you're successful, great. And if you're unsuccessful, it doesn't really reduce your chances of having a final success if you do a vitrectomy, within about a week. John, what do you think?
Yeah, I think you brought up some good points. That the one paper I'd call out would be from Stanford with Priya Vakharia, where they did show an increased incidence of pneumatics on Friday. So I do think access to the OR and timing of presentation do affect, in some cases, the surgical choice. I do think that you can sometimes lose things by doing a pneumatic first. You can you can create additional breaks inferiorly sometimes with dissection of the vitreous with the gas bubble. You can also make posterior feathering of the lens, so you may have a harder time with the vitrectomy at the 1 week. And I think what you do gain with the vitrectomy, that may not be, it just depends on how you shave, but I think you can identify really small breaks with this careful scleral depression and good peripheral shaving with high flow. And I think we can still do better with higher success rates with vitrectomy. So I still think there is a role for pneumatic in select patients, but I do think you're taking control of the eye more quickly and ensuring that you're identifying all the breaks under high magnification when you're examining in the OR. I think that's the main thing I worry about with pneumatics, is missed breaks.
No, I certainly agree with you completely that this, single surgery success rate is higher with a vitrectomy. I think that's been validated by many studies. The question is whether or not you're losing something if you put a gas bubble in and fail and then do a vitrectomy. If their hyaloid is attached, definitely you can cause some inferior breaks, and feathering of the lens is a very good point. But the fact that, at a year, they're still having some measurable differences that can be symptomatic really gives me a opportunity to reconsider what I generally have been doing.
I would consider it on pseudophakic eyes, not on phakic eyes, and definitely eyes with small breaks, not large breaks. In phakic eyes, you can lose the lens, and you can lose the lens just by the patient waiting in the pre-op area, lying flat, and then getting wheeled in very quickly. There's going to be feathering on the lens, and then it's going to be a tough situation. In pseudophakic eyes, yes, I think it might play a role with small breaks, not large breaks. I wouldn't do it in a patient that has a 1 clock hour, 2 clock hour horseshoe tear or a GRT or things like that.
Yeah, I don't think anybody would disagree with you about that. And do you guys think that the pivot and align trials are the same, or are there significant differences that we need to pay attention to? Priya?
I think they're generally about the same. They measure two different things. The pivot trial measures outer retinal displacement. The align trial measures, the pivot trial measures outer retinal folds. The align trial measures retinal displacement. So they're looking at two different, the pivot trial looks at the en-face slab OCT, whereas the align trial is looking at the fundus autofluorescence. But I think in essence, they're looking at very similar things. Although they do mention in the pivot trial that the retinal displacement is actually more related to the gas bubble and mechanical pressure from the gas bubble and subretinal fluid moving. But in my mind, I think at the end of the day, it boils down to the anisoconia. That's really what we're looking at here. Whatever we see on an image is not as important as what the patient's experiencing. And so in my mind, they're looking at very similar things.
Yeah, I think that brought up a good point, Priya. One question in my mind is, I didn't know if I followed the physics of their proposal that there's less force on the retina with a 30% gas bubble or 70% gas bubble or 80% gas bubble. I don't believe that is how the surface tension of the gas works against the retina, but I think there may be some additional conversation around that.
Well, thanks everybody for this excellent discussion on two really interesting papers. I think this was a lot of food for thought, and I'm sure there's going to be more to discuss in the coming years. So thanks to the audience for listening to New Retina Radio Journal Club with VBS, and please stay tuned for further episodes.